Picture Bangla Convention Center, New Town, Kolkata.
So we are all assembled here for the 63rd Pedicon, which is the annual conference of the Indian Academy of Pediatrics. 17th of January 2026 is the first day.
Almost all the experts in this field of pediatrics have come here at Kolkata. Pedicon, Kolkata, what is the city of God? The venue and everything is really very joyous. और ये इतना बड़ा कॉन्फ्रेंस यहाँ ऑर्गेनाइज हुआ है, वेरी वेरी एक्सीलेंट कॉन्फ्रेंस जो लग रहा है, बहुत ही अच्छा कॉन्फ्रेंस हुआ है मोस्टली कोलकाता में. दिस इज द फर्स्ट टाइम आई एम सीइंग वेरी 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 एक्सीलेंट कॉन्फ्रेंस हियर. Innovative, informative, there are so many seminars, so many stalls, and the standard is at par or better than international conference. And it's a huge comprehensive program. So 5 day jam-packed program. It's 600 scientific hours with so much of well-ended speakers event.
Why do we do such national conferences? Basically, we need to remember science keeps on moving. Always update ourselves with the recent advances. In the next 5 days, we have 1,500 plus national faculty who's going to be here. The conference is going to be attended by more than 8,000 individuals from all across the country. So there is uniformity in teaching, there is an exchange of knowledge, there is advocacy, there is discussion of policy.
So the planning starts about 1 year ago. 1 year ago, when the another conference earlier conference ends, the planning starts different committees. I must not forget about the entertainment part also.
I think it is extremely important to have such national conferences where there's a lot to learn from each other. Socialize in the evening because that is the time we get to collaborate.
City of culture, we are enjoying this each and every moment. At this, when
We have arranged one is Abhijit and one is Preetam, so we are, going great plans that way also.
we congratulate the Kolkata team for taking on tremendous efforts and super hospitality.
Hello. Good afternoon, everyone. Good afternoon, everyone. My name is Vivek. I'm part of the marketing team from Helion, erstwhile GSK Consumer Healthcare. I think, first of all, warm welcome to all of the faculty members, speakers, and all the delegates who are there in the hall. I think, personally, I would like to thank each and every one of you. Take out time, especially on the Sunday afternoon, and you decided to spend the time with us in the session, which is going to be there for next 1.5 hours. From Helion side, from the marketing side, I would like to personally thanks West Bengal Academy of Pediatrics, also the IP UK branch, for no really helping us put together this program, so that all of us could really go through the sessions and for the next 1.5 hours. I think also I would like to personally thanks all the speakers and the delegates, especially Dr. Ratanu sir. I think, thank you sir for guiding us and for helping us to organize this program. Dr. Amita Sinha ma'am, also Dr. Suman Poda sir, Dr. Dr. Sameek Hazra sir, also Dr. Amitabh, who is also the part of the program today, Dr. Agni sir. I think welcome to all the speakers. Also Dr. Bivan Saha, who will be joining us also from the UK virtually, and Dr. Santanu Ray. I think, again, welcoming all the speakers and the faculty members. I think before we start, from the Helion side, I have a small video play. So if I can request the team to help me play the video. Yeah. Yeah. So Helion, which was erstwhile GSK Consumer Healthcare, is known to have global products. You must have heard of brands like Voltaren. You must have heard of brands like Crocin, which is there in India. And also we have a Panadol, which is globally available. All of the brands are leading in the market globally. Also we have Centrum, which is world's number one multivitamin. So all the brands are global. The quality is ensured, so that we deliver better health every day is our motto, right? So I think, before we start, I think I would like to request all the faculty members and the speakers for the on the stage to just start the session with a lamp lighting ceremony. So if I can request all the members to please come on stage and let us start the session with the lamp lighting ceremony. Thank you so much.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डवण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मा पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमां आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहा हस्ते स्फाटिकमालिका वन्दे तां परमे
So I think for the proceedings, I will just hand over to Dr. Amita Sinha, ma'am. She's a state coordinator for IP Action Plan. Over to you, ma'am. Thank you, ma'am.
So thank you. First of all, I'd like to thank Helion GSK, erstwhile GSK, for arranging this wonderful CME. So a very good afternoon to all of you who have taken your precious time out on a Sunday afternoon in a hot and sultry, humid afternoon. So this today's program is a bit different. It is one of the programs which is going to be conducted subsequently, and here we will uh, have a very small videos which will show you which we had Pedicon 2026, I think all of you know, and the memories of the Pedicon 2026 and the success that ensued will be shared with all of you because it was all of your program as well. So after 13 years we could arrange this Pedicon, uh, and we could do it successfully, and most, and I think 99% of the delegates had had very good words to say about the Pedicon. And thanks to all the organizers and all, it was a great team, and I think most of you were all a part of the team. And of course, the audience also was awesome, and we had around 9,000 delegates who attended this program. It was a 4-day long saga, and along with preceding 2 days, where we had around 13 TOTs and 26 workshops. And before that, also, it was a different program because we could arrange a multi or state cultural program encompassing all these states. So they put up a dance program, and we could arrange their stay and their practice. And finally, they put up their program on the inauguration day, which was really awesome. So there were some different things which we could arrange during this Pedicon, and the concerts which we had, the artists who came down were really appreciated. Preetham's night was attended in full swing and in full numbers, and also Abhijit's concert was also well appreciated. So most of the venue, the food, and the ambience and everything, I think most of the people had a good word to say about it. So we would share some memories of this Pedicon, and one of the pillars of organization was Dr. Atanu Bhadro, and who was the chief organizing secretary. And believe me, it was under his guidance from day one. And day one was not on the day of the conference, of course. It started, I think, around 2 years back when we actually won the bid for Pedicon. And before also winning the bid, that was also a battle. So before winning also, we had to do so many things to just win the bid for Pedicon. And after winning the bid for Pedicon, right from the last whole 1 year was full of meetings. And thankfully we had online meetings, because, and of course we had to also travel to Mumbai, Delhi and Chennai to arrange sponsors and meet the farmers individually and personally. So all those were the brainchild of Dr. Bhadro, and it really paid off. So we had good participation. We had good participation in the form of delegates and farmers. And the venue, though initially many said that it would be small, but it was really compact, and everybody had a place in that conference. We also could arrange a few different things like the heritage of Bengal, which was showcased, and right from we had a video which kept on playing during the conference, and it showed the heritage of Bengal in the form of our forefathers who have left a rich legacy for today's world. And right from Subhash Chandra Bose to Rabindranath Tagore, and subsequently so many scientists, medical personnel, and also artists across all spheres. So Bengal, as you all know, is a rich has a rich basket of heritage and talent, which we have been given through our generation. So there's a rich legacy of these talent. So we could showcase that also during the pedicon. And there were many other things also which we could do. The paintings of our own doctors were showcased, and the photographs which were clicked by the doctors of Bengal and outside, that was also showcased. So many things, and the handlooms, and many things which mark Bengal, the craftsmanships and the handloom of Bengal were also showcased. And not to say, of course, about the scientific content, which was crisp and which we could finish every day on time. The sessions were completed on time, and that was something which everybody applauded for. So I think now I will hand over to Dr. Atanu Bhadro. Uh, yeah, so if you could say a few words, because it was from day one his conference, and we were all, happy to be a part of it. And, despite all the tensions, all the hard work and everything, in the end, since the result was good, all's well that ends well.
Initially, for those of us who could not be there, I'll just request you to play the video. Yeah, I don't know.
I'm in Paed Vishwa Bangla Convention Center, New Town, Kolkata.
So we are all assembled here for the 63rd Pedicon, which is the annual conference of the Indian Academy of Pediatrics.
17th of January 2026. The first day.
Almost all the experts in this field of pediatrics have come here at Kolkata. Paed Kolkata, that is the city of God. So, and everything is really very joyous. ये इतना बड़ा कॉन्फ्रेंस यहाँ ऑर्गेनाइज हुआ है, वेरी वेरी एक्सीलेंट कॉन्फ्रेंस जो लग रहा है, बहुत ही अच्छा कॉन्फ्रेंस हुआ है मोस्टली कोलकाता में. दिस द फर्स्ट टाइम आई थिंक वेरी 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 एक्सीलेंट कॉन्फ्रेंस. Innovative, informative. There are so many seminars, so many stalls, and the standard is at par but better than international conference. And it's a huge comprehensive program. So 5-day jam-packed program. It's 600 scientific hours with so much of 1,200 speakers have come.
Why do we do such national conferences? Basically, we need to remember science keeps on moving. Always update ourselves with the recent advances. In the next 5 days, we have 1,500 plus national faculty who's going to be here. The conference is going to be attended by more than 8,000 institutions from all across the country. So there is uniformity in teaching, there is an exchange of knowledge, there is advocacy, there is discussion of policy. Actually, the planning starts about 1 year ago. 1 year ago, when another conference, in earlier conference teams, the planning starts with different committees. I must not forget about the entertainment part also. I think it is extremely important to have such national conferences where there's a lot to learn from each other. Socialize in the evening because that is the time we need to collaborate.
City of culture, we are enjoying this each and every moment. This when
We have arranged one is Abhijit and one is Preetam. So we are, going great plans that way also.
congratulate the Kolkata team. It is a tremendous effort and super quality.
Thank you. So, as Dr. Amita just mentioned, it was almost a 2 year journey. So it was not very easy, but for the first time, there was a 800 member organizing team. The whole of West Bengal participated in it in a way that we never expected. And it is, we are happy that the Pedicon was one of a kind, not because of the 9,000 delegates, not because of almost 500 hours of academic performance, but because all of us for those whole 2 years worked together in a unison and in different with different responsibilities. That was a challenge. We all know that all teams, whoever is working, whether it's in the industry or it's in the IAP format, united effort is the basic thing that we all need. So we could reach out to all of you. But before I say a few words, I would request and introduce a gentleman. It would be a real introduction because none of you had seen him working or know him personally. So I would request Mr. Raghu to come on the stage. He's an academic entrepreneur. He fell in love with Mr. Raghu, please. When working on the Pedicon, we are discussing how we could work. Then we met this gentleman, and he stays in different parts of the city and different parts of the world. So I cannot identify him with any particular city, but he came up with a very good idea of selecting the lectures and see that those who could not attend or those who wanted to refresh their knowledge, these lectures were picked up. The individual academic the academic faculties, they were asked for their permission and the book was published. During that time, we were thinking that whether we could continue the academic process all throughout the country in a form that Pedicon initiated, and then we came out with this idea. Thanks to Mr. Vivek of Halion who participated in it. Yes, Mr. Raghu, you want to see a few words?
Thank you, Atanu sir. I can only be grateful at this point in time. Of course, my sincere thanks to Helion and Mr. Vivek for giving us this opportunity. I hope the Paed Connect initiative is going to be well appreciated, and this is just a recap of the success of Pedicon. Thank you all.
Yeah. Thank you. So we plan to move out across multiple cities in the country with a thank you journey. Yeah. So it was one of the most anticipated pediatric congress. Almost 13 years. We moved to Calcutta after 13 years, and science, leadership, and culture were all noted. We are all sincerely working to have a brilliant participation in all of them. We had unmatched academic depth. IAP UK for the first time as a delegation was participating in the Pedicon, and we had almost 1,800 faculties from across the country and across different parts of the world also. So there were 70 international faculties, massive networking and national and international participation, the latest global practices, World Health Organization, the UNICEF, everyone participated, and we were looking to advocacy also along with the academic performance. So it was public health relevance. We all know the ex-Miss India was there to give input to the advocacy for HPV vaccine, and there were celebrity. As a celebrity, she participated in our HPV prevention advocacy, and now we can see that shortly we have started across the country the HPV mass campaign. So it was a mass outreach. We looked into environment, we looked into tree plantation drives. It was a 1 year journey. So across that journey, we had plantation drives in different parts of the country, and a sustainable conference vision where hundreds of children, hundreds of medical camps were organized. During those 7 days, almost 700 children were fed during this out of the funds of the Pedicon. And just now, at the beginning of March, we had at the beginning of this month only, April, we adopted a village near the Purulia and Paschim Bardhaman border, which has been renamed as Pedicon Village. And this project is Project Palash Abha. We have started and taken up the responsibility of educating and giving food to these children. So these were all there: food support initiatives, health camps, social responsibility. Never in the history of Pedicon had this been taken, these initiatives had been taken up. So we had 11 teams participating in the cricket carnival. We had the Pedicon Idol, the doctors singing. In fact, the dances that you saw in the inauguration, they are all pediatricians from different parts of the country. So it was fellowship beyond academics. And again, West Bengal is known for different pioneer movements. And the first pioneer thing was about the inauguration. There was, I already mentioned that the doctors of different parts of the country, different states, they were participated in the dance performance. And for the first time, no politician was invited to the inauguration. The whole inauguration was done by doctors, the different officials of the West Bengal Health, and different officials from outside. So it was totally a doctor-led inauguration and a presidential night. All delegates were inward. So it is not a conference, it is a movement, and we want it to continue. And thanks again for this Paed Connect initiative. And we hope that you enjoy the academics. It will be a short but highly intense with selected faculties from Calcutta and from beyond. Also, Dr. Bivan will be joining in from UK, and of course, we'll be having a very short academic session. So over to Dr. Amita to continue.
Yeah, so I think we'll move on to the academics, and Halion wants to felicitate the speakers with bouquets. So uh, I think Dr. Otanu, you can come here. Pahari sir, Dr. Amitabh Pahari sir, please. Ognida. Shantanan. Dr. Shumon. Dr. Shumon. Shomik. Dr. Shubhashish Bhattacharya. Sir, please.
একবার করে স্টেজে টকটা আমি ওই করে দিচ্ছি। Infections in nephrotics age 8.
যেটা যেটা সুবিধা তোমরা যেরকম
হ্যাঁ আমি বিমানটা হ্যাঁ যেখানে বলবে কোথায় চেয়ার দিয়ে ঠিক আছে ঠিক আছে পরে আগে শুরু করি তারপরে Good afternoon, everybody. I am really thankful to the organizers for giving me the opportunity to be a part of the program. So we'll not take time. Today we'll discuss about the congenital CMV infection, which is much underrated and under-discussed. But in our clinical practice nowadays, we are getting a lot of cases having congenital CMV infection. In fact, sensorineural deafness is the most common cause is the congenital CMV infection, non-genetic cause. So it should not be taken lightly. In my practice, I have seen a baby premature born whose mother had a congenital CMV infection due to CMV infection. Even I have found 2 cases of autism who had a congenital CMV infection. So though it was much underrated, but now really we are in our clinical book, and with the lab test and the PCR test, we are finding that CMV infection is a matter of concern and we should discuss and know how to deal with it. So for that, Dr. Bivan Shah is there, who has a very good speaker, and he is with us from UK. So we'll move to him. Thanks. So Bivan, let's start. Bivan, can you get me? So Bivan, let's start with the congenital CMV infection.
Can you hear me?
Presentation, let's start. Thank you.
Am I audible?
Yeah.
Thank you very much. Thanks, Dr. Bhadro, Amita, and all my friends back home. And I think it is one of the most memorable pedicons that I've attended. I've been going to pedicons for the last 5 years, and I think when Atanuda spoke to me about this concept, and I spoke to Mr. Raghu as well, I was stuck in India for the current flight disruptions. I think it struck me that I think this was a novel idea for which IAP UK was a part of and so I spoke to all my colleagues here, and there was a lot of appetite for this, I believe. So thanks to the entire organizing team, Paed Connect and Halion, as well as my very dear friend Shantanu, who we were registrars together long time ago. And so I think, yes, I believe we are speaking on congenital CMV. So I can see the main screen. Am I sharing or is someone else sharing? Can I share the screen?
Kindly go ahead, sir. Kindly share from your side.
So is it visible?
Yes, sir. Yes.
Okay. So I'm a pediatrician with neonatal pediatrician working in Manchester. I've got some interests in infectious disease as well as cooling and bronchopulmonary dysplasia. I've been in the UK for the last 17 years, practicing as a consultant for the last 9 years approximately. So without going into much detail, I'll go into the topic proper. Slides are moving.
Kindly double click on your slide, sir. Just double click.
Okay.
Yes,
Yeah,
yes.
Okay, so as we said, it is a big burden, congenital CMV. We see quite a number of cases in the UK, and I'm sure there is a big undiagnosed cases which come into light many years down the line when they present with multiple neurodevelopmental abnormalities, difficulties in growth, difficulty in neuromotor manifestations, difficulty in development, as well as presents later with things like autism and neurodevelopmental abnormalities. So my whole point of doing this today is how can we isolate the burden and what are the soft detectors and soft markers, as well as how to standardize some sort of management plan, and how do we involve the entire multidisciplinary team. That was the whole point of this discussion. It will be a bit interactive. I will give the lead to Shantanu at some points of time where he can just reinforce some basic take-home messages and take-home things that you should be going home with today at the end of this talk. So as Shantanu quietly said, that it is the most common cause of most common non-genetic cause of sensorineural deafness in the world. It is a major cause of neurodevelopmental disability, and the problem that we face is even up to this age, there is no standardized biochemical marker or test which can predict sequelae. Yes, we get a CMV, but we don't really sometimes understand whether that is a congenital CMV or whether it is a acquired CMV, whether it is a maternal CMV which has been acquired or this is something that the baby has. So I think the problems are multiple, and down the line we find that we missed the boat because the areas of treatment are very less. A majority of them cases are asymptomatic, and finding the best window for treatment is very difficult. As we know, the highest rate of vertical transmission is in the third trimester, like any other viral infection. However, the most severe infections are the ones that affect mom in the first trimester. As we said, that is asymptomatic infection is approximately 85%. That's the burden. If you look at the burden, it's more or less similar in both developing and developed countries. About 100 to 200 live births globally. If you look at the prevalence, it's between 1 to 6% in both countries. However, less diagnosed in developing countries than developed countries. Asymptomatic in 85% and symptomatic in about 15%. However, if you look at that, I'll come to this maths in a minute. The symptomatic ones, half of them develop long-term sequelae, whereas the asymptomatic ones, about 10% develop long-term sequelae. And as we said, a commonest is hearing loss, where that's the first presentation, but later on goes to develop neurodevelopmental sequelae as well. Now, if you look at the maths, so this is more or less the maths that I was talking about. So if you've got 5,000 live births, if you look at this, is about 85% have no CMV, whereas 35, which is about approximately 15% have CMV, out of which 15% are symptomatic, out of which 90% are asymptomatic, which is about 30 and 5 babies here. Out of these 5 babies, 50%, 1 in 2, will have a hearing loss, which may get worse, which is about 2 to 3 babies. But out of the asymptomatic at birth, out of the 30 babies, again, 3 babies will develop a hearing loss. So all over, whichever side you take, approximately, if you have got a birth population of 5,000, there'll be about 2 to 3 babies each year that are identified with CMV testing. Babies that fail the newborn hearing screen. I think hearing screen is one of the prime detectors, but a first hearing screen, if negative, should be subjected to a further hearing screen down the line within the first 7 to 10 days of birth. And if that is positive, or if the first one is negative and the second one is positive as well, these ones should be tested for CMV, which I'm going to come in a minute. This is where we have just, this is the modes of transmission. And Shantanu, do you want to come in here?
Actually, for a pregnant mother, one should know how CMV is contaminated. It mainly comes from toddlers, changing nappies, kissing the toddlers, and secretions are to be avoided in all pregnant mothers, so that the CMV is not contracted from the toddlers or the kids. Like nurse, as Bivan was, and we were discussing, that a nurse who is pregnant should be always not be in duty, because diaper changing and is a main source of infection. So that be kept in mind. Initially, the perinatal infection and the postnatal infections to be though very asymptomatic, it should be different from the congenital CMV infections. Why? Because the congenital CMV infections have a lot of complications, whereas the postnatal, which passes through the breast milk, has very less incidence of neurological problems. So
yeah, am I audible?
Yes, sir, please.
Yeah, I think if I think just Shantanu stopped abruptly, so I was just thinking whether he's still speaking or not. Am I audible? Am I audible, guys? No.
Sir, you're audible, sir. You're audible.
Okay, so as we clearly said, I think this is one of the most important learning that we are. If you have got a case of a congenital CMV, or you're suspecting, I wouldn't say case, if there is a suspicion there is a congenital CMV in the unit, and you know that there is a pregnant colleague around in your unit, he or she, she should be barred from looking after this child. So it is important, nursing as well as medical staff, if there is a suspected CMV, then they should have a barrier nursing, where any pregnant mothers or any pregnant ladies, nursing or medical, should be barred from looking after this child, because there is a significant risk from body fluids, especially when you are changing diapers, when we are giving suction, when we, so the secretions, any sort of secretions can be transmitted and can affect the unborn fetus. We all know the symptoms and signs. I'm not going to the main, the detailed discussion about it. The most important things that we look for when we are trying to screen is microcephaly, less than 2 standard deviations. Together with, we know there are, CMV causes massive injury to the cytopathic vessels, and most of the manifestations are due to these vessel injury. We have things like purpura, we have things like hepatosplenomegaly, proper rash, we sometimes call it a blueberry muffin rash, thrombocytopenia, as we already said. But the most important ones, that if we have these markers or these factors which will influence our management, the most important thing is a scan. To start with, we can do with an ultrasound scan of the brain, which can pick up the intracranial abnormalities, mainly the calcifications to start with. However, if you get a calcification in the brain and there is a suspicion of CMV, there should be an MRI done within the first 10 days of life to substantiate your findings, especially things like cortical migration defects, things like calcifications, white matter changes, things like pachygyria, which can have long-term complications and long-term effects on the developing brain and the further neurodevelopmental abnormalities that may present later in life. As we said, these were the mainly effects of the blood vessels injury. Now, I think there it comes up, who do we screen now? I think this is probably a very, very important slide. You can take a picture of this slide, which probably, if you want to. So there may be two concerns. One is an antenatal concern, and it is the postnatal concern. The antenatal concern, who to screen; postnatal concern, who to screen. I think the postnatal or the neonatal concern is very clear. Sometimes we have petechia, we have purpura, we have a prolonged jaundice, which may be conjugated. There is an element of a small head, which is there's a symmetrical IOGR with a small head and a small body, less than 2 standard deviations, and then we have seizures with no other explanation. So that, if we have that, probably the screening becomes easy. The problem is with the antenatal concerns. Who do we screen? I think the most important thing is a seroconversion. So I'm not sure how rampant or is TOT screening in pregnancy in India. Is it done as a blanket or is it done in selective centers? But in the Western world, all mothers go through a TOT screen in pregnancy. Now, if you have a TOT screen which is seronegative to start with and becomes negative at booking and becomes positive, so there is a proper seroconversion, or with CMV IgM positive with avidity of IgG very low. I think there is a confusion about this avidity. If you look at about IgM and IgG, IgM we all know tells us it is acute infection, whereas IgG is past infection. However, in the CMV concept, the IgG comes always with a high or low avidity. So low avidity means there is a recent infection. So IgG with low avidity with an IgM positive will have a greater risk of a congenital CMV than IgM positive with high avidity. So the low avidity means it is less bound. The antigen and the antibody is less bound. So there is more chances that it has been occurred within the last 2 to 3 months, whereas the high avidity means it has occurred some time ago. So these tests have to be interpreted very carefully, and IgM and IgG when we do in mom. So the most important marker is a seroconversion, which was negative to start with and have now become positive in some greater dilution. And then an antenatal ultrasound, together with, when you get these features of low avidity with IgM positive, we do an antenatal ultrasound, and that can give you things like, as we all know, they can give you microcephaly, cavitations, ventriculomegaly, calcifications in the brain. And then if facilities exist, we can do an amniotic fluid CMV PCR, which is available in the UK and the US. I'm unsure whether it is available in the Indian subcontinent or not. And then if all this is positive, as we said, this mom may be CMV positive, but there'll be a very, very few fraction that will be transferred to the child. So a lot of these babies can be born with CMV, but maybe clinically asymptomatic. So As soon as this mom is picked up in pregnancy, there should be an alert going on this mom's notes that as soon as this baby is born, within the first 7 days of life, we should send a urine or saliva for a CMV PCR. So we'll come to this saliva and urine. I think urine is done in most of the Indian centers at the moment. There are few centers of in India which does saliva PCR as well. I think Shantanu, do you want to come in here and tell us about where saliva PCR may be done? Shantanu, can you hear me? Kishore, is anyone speaking from the audience or anything that is coming up that Shantanu, because Shantanu was silent throughout?
Yes, I'll check.
Just check if Shantanu wanted to come in here.
Me.
So
our labs nowadays are geared up with this test, and we are doing the from the saliva and the urine. Though the urine has a false positive rate high, so we prefer the saliva one, and we are doing that.
And where is it done? Especially any
it's a Lal lab. It's from Lal lab, and the SRL Ranbaxy it was called initially. Nowadays it's called SRL labs.
Okay, thank you. Thanks, Shantanu.
Thank you.
Okay, so as we said, a large amount of these viruses are shed in the urine and saliva. So we prefer saliva because there has been a high risk of contamination in the urine and collection of urine, which it is sometimes not possible with the nappies, with the stool contamination and things like that. So I think saliva is the preferred, but urine is, if you can collect a sample of urine which can be uncontaminated sample or a clean catch urine, I think urine will give a similar result to you. But the problem is you have to do it within the first 3 weeks because treatment has to be instituted for best results. Treatment has to be instituted, if at all, if treatment is needed, treatment has to be instituted within 28 days of life, which I'll come to in a minute. So this is how you collect the saliva. So if you look at here, so baby should not breastfeed within the last 1 hour. Bottle feed should be fine for the obvious reason. So if breast milk has got the CMV and it goes on to the baby and we do the saliva, so you will not know whether it is a congenital CMV or is a postnatal acquired from mom CMV basically. So what you do, if you have to put the swab in the mouth between the gum and the lips, and you have to wipe it well, make it wet for at least 60 seconds. And then you have to, it's similar to any viral PCR, and then you can use it in the viral PCR box and send it across. It usually yields a result within 48 hours, and it tells you about the PCRs, and then you can thereafter you can send bloods on this baby to get a viral log, which will determine your treatment. I'm skipping this slide. Shantanu, do you want to ask? So there'll be some practical points here. The parents might start asking questions from now on, so which will make it into a dialogue now from here. Shantanu.
Yeah. So let's make it more interactive. Actually, the congenital CMV infection nowadays we get because the mothers from the first trimester, when they progress to the last trimester, the transmission of the CMV virus increases from 5% to 50%. That's a huge the passes from the cervix and the urine. So many times we parents say that how much chances are there that my child, the mother having CMV infection to be nearly diagnosed, or there is suspect of CMV infection. So what is the probability my baby will contract the CMV infection or congenital CMV infection? So Beyond, can you highlight on this?
Yeah, as we clearly said, so if you go on your birth rate on your unit, so if every 5,000 babies, 2 to 3 babies will probably have CMV, but all of them may not need treatment. So basically they may be affected, as we said, but they may be asymptomatic. So especially if you're a term baby and you can contact CMV, but it just will manifest as a cold. It might not give you symptoms. So the problem starts if you're immunocompromised, if you're a bit preterm and you have contacted a vertical transmission, especially during the 3rd trimesters. But approximately 2 to 3 babies in about 5,000 will have CMV.
Yeah. So the prospective study says that 90% of the babies are asymptomatic, and there are 10% babies have these chances to contract the infection. Now we'll move to the second question. As we know that CMV causes the vestibular damage and causes a sensorineural deafness. So many parents come and ask, "Jay, what will happen if my baby having a congenital CMV infection and a hearing loss? How to deal with it?" So Biman, how you go in
Yeah,
your
so I
setup?
think it is a tough call because uh, treatment has to be instituted, as we said, within for best results has to be instituted within 4 weeks, which is about a month of life, basically. So that is why we said it should be the saliva or the urine should be sent within 21 days. So once these results come back to you, you have to give them quite a clear picture that yes, this baby's we need to start treatment. So because it may prevent further neuronal damage and further hearing abnormalities. So a baby who has failed the first and second hearing test and has got a CMV positive will qualify for treatment if parents agree with a oral antiviral, which I'm going to come to a minute. This has to be instituted within 4 weeks of life to prevent further hearing loss or further problems in neurodevelopment. All the research that has gone in has been shown to say that it has to be started. Yes, there is research which is going on, which will be the next question. Probably, can I treat the baby later? That's probably will come to the next question. But the whole point is, yes, there is research that is going on that you may be able to treat 12 weeks down the line, but the effect of that treatment is still not known. So the best is to start treatment within a month of life. Next question.
One thing I want to add on, that in case of, we normally do newborn OAE testing, autoacoustic testing, but in case of normal OAE, if we think that mother having a CNV infection, we should do a ABR. ABR should be done in a case of suspected CMV infection. So we move to the next question.
So basically what Shantanu was saying is OAE is the first screening tool, isn't it? So if OAE is negative, that doesn't mean that this baby shouldn't. So if there is a suspicion of CMV from a mother, or if the mother has got a diagnosed CMV and the baby has got a negative OAE, they should go for a further test, a more advanced test, which probably should happen with the first 7 to 10 days. This is what I was saying. And if that is positive, then this parents should be counseled about getting a CMV test done, and thoughts about treatment should come in. Next question, Shantanu.
Yeah. So many parents come to our chamber and say that the test is very hazardous, taking specimen from saliva and all those things. Doctor, can we delay the test for a few days or few months? So normally, how you counsel the parent at that time? How you say? We know that the golden time is 28 days. That's the best time for diagnosing the CMV and the postnatal infection, also differentiating. The 21 days is the dictum. Yeah.
Yes. So if baby has failed the hearing test and you have got a CMV, you are suspicious, there is a suspicion of CMV, I think you have to, it is a balanced decision at the end of the day, because treatment is for 6 months. There are issues with treatment, but I think currently the oral treatment, the effects of the oral treatment probably trumps the issues that we had previously, that we had to get intravenous treatment. So the best treatment should be given within a month for best results, to prevent further hearing loss and to get best neurological outcome in long term as well.
So we move to our next question. As we all know that postnatal infection we get in many cases due to the breast milk transmission. So many patients say that my mother had a CMV and the infection is gone after birth. Then how is the outcome?
I think we have already touched on this. So
we have discussed this thing. So we can move
on.
Well
baby and it just presents as a cold. So it's not. The problem is
really asymptomatic.
Is asymptomatic, but the problem is here the transmission can occur from that baby to another person as well. So because it is unlike other viruses, here the babies can transmit it to adults as well. So that is the most important thing. So there should be no one who is pregnant or suspicion of pregnancy that should handle this child, because if this child has contracted CMV and has got CMV, it shouldn't pass to another adult. That's the bottom line. but he or she will be asymptomatic. It just will pass as a slight cold.
And moreover, Bivan, now we are seeing that the post infections, though thought to be asymptomatic, nowadays research are going on that might also have some complications. So studies are going on that.
10% of that, yes.
Yeah. Now, the last question I come to this session is
we
that
already addressed this.
Normally we know the golden time is 28 days to start the treatment to prevent the neurological complications and the deafness portion. So a child who has been diagnosed after 28 days of life, so what to do? Shall we treat or shall we think that it's a futile? So how you go?
I think on a balance of probabilities, if the child has got CMV and there is some subtle markers of congenital CMV, or the child has has failed the hearing test, and the child is otherwise clinically well and has got CMV at which you think it has been congenitally. So it should be, because there is some research going on that can be started between up to 12 weeks as well. So it should be an open discussion with parents. If parents are willing for the treatment, because that anti-treatment has to continue, and it's now oral treatment. It's not like IV treatment as it was past. So it should be a balanced decision, taking parents into account, telling them of all the complications plus the issues that we can have with the medication. So it should be an open discussion with the parents based on which you can start or stop treatment. Because in one of our cases, when we had because as we said, it's very hard to diagnose whether it's a congenitally. So there was a baby who failed the second hearing test and but was positive for CMV. We were not sure whether it was a congenital or an acquired CMV. We started treatment after 12, but we went for a further hearing test down the line at about 3 months, and which was felt to be the baby had passed, and we had stopped treatment at that time. So it is a balanced decision, taking parents on board that this is my chances of treatment. This is what I'm going to achieve. These are the complications of treatment. And then you can only take that decision between 1 month to 3 months of life. So it should be an open discussion.
Yeah. So let's move on the next slides.
I think we have already, mainly this is with children's body fluids, avoiding sharing foods. The most important thing is we should avoid kissing on the lips. I think we do it a lot in our subcontinent as well. Baby should be kissed on the forehead as a practice other than the lips, because you never know what will transmit from your lips. Pacifies in the mouth. So avoid cleaning a child pacifier in the mouth. If it falls on the floor, you usually clean it and then put it in the mouth. So try and those are the small bits and pieces that I'm going to. So as we know, most of these can be taken care of by rigorous hand washing, like all viruses. And this is what we have already portrayed, basically. Now, who to treat? I think all the researchers have gone in. We said we had to treat within 30 days. And if the baby is more than 32 weeks. So all the studies that have been gone on has been for babies who are 32 weeks or higher, because the toxicity of drugs may not be suitable for babies who are less than 32 weeks gestation. So the babies have to be late premature or like 32 weeks onwards, or less than 30 days of life. Now, the problem now comes is who to treat. So if you say moderate or severe symptomatic disease, what do you classify as moderate? What do you classify as severe? If it is neurological CMV, then it goes into the severe spectrum already. So who do we classify as moderate? Because even the mild ones do not need treatment. So what we have as a rule of thumb, we have made it to a sort of a ruling practice that if 2 or more systems are affected, then we should go for treatment. So say a child has got an abdominal symptoms with increased liver markers together with thrombocytopenia, more than 32 weeks and about less than 30 days of life without CNS manifestations, they should be brought out for treatment. Whereas only one system affected, you can keep it under follow-up and see where we are. If it develops any symptoms down the line, we always have that window of treating between 30 days to 12 weeks of life. So it is, again, a very critical and balanced decision, taking parents into account and everyone into account. But any sort of CNS disease should be treated irrespective of if there are other systems involved or not. Is it clear? Or Shantanu, do you want to come in here by any chance?
Yeah, it's very clear. But I want to add on one thing. that head circumference should be measured in a suspected case of congenital CMV infection, because microcephaly is the predictor of the neurological outcome. And if we get a chance, we should do MRI of brain to see what will be the cognitive defects and the motor disability of the child in future. So that should be kept in mind, and that should be the way to go ahead. Next, B1.
Yeah, so ideally should do an MR probably at about 3 months of age, where you have better sulcation and better, especially if the baby is premature. So don't do it immediately to guide your prognosis.
In the follow-ups.
Do it down the line, few months down the line to guide your prognosis. But then again, there is one fallacy with this CNS disease, because you are suspecting a CNS disease. You have done a blood PCR which is positive for CMV. We came across a baby who went for a lumbar puncture, was about 33 weeks of age, and we suspected CMV. We went for a lumbar puncture. The lumbar puncture was slightly blood-stained, and it came back as PCR positive. This baby was not showing any other signs of CMV. Now, it was very difficult to diagnose at that point whether that PCR is positive from the blood that came out from the CSF or whether it is clear CNS CSF. So you have to get a clear CSF if you have to diagnose a neurocMV, because that will guide your treatment. So we have to be very balanced in your approach in how you treat and what you treat.
Yeah.
Sorry, I think previous slide is... Yeah, so this is our very studies here. So I'm not going to do individual studies because of time factors, but the bottom line is previously we used to use IV ganciclovir, which has its own complications, long-term IV treatment, its complications, long line infection. So now the bottom line of all these studies are oral valganciclovir is the treatment of choice, and it has got similar effects with similar efficacy if you are giving oral ganciclovir 16 milligram per kg every 12 hours for 6 months. So oral ganciclovir is available and is the treatment of choice for congenital symptomatic or severely symptomatic CMV. And it has got equal effects than intravenous ganciclovir, which was thought about the best drug in the past. So that is your oral ganciclovir. That is your dictum for treatment. As we said, the usual complications are, to start with, usually happens within the first 6 weeks. And usual complication is oral ganciclovir is neutropenia and a bit of thrombocytopenia, but neutropenia is main. So full blood count should be monitored every week for the first couple of weeks, and thereafter every 2 to 4 weeks for the whole length of treatment. There is another manifestation which sometimes complicates pictures, which we had again with a very complicated CCMV. There can be a mild ALT rise, which then again is sometimes difficult to find out whether this ALT rise is from the CMV itself or it is from the valganciclovir that you are giving. So it is sometimes very hard to differentiate which is causing it, in which case you can take two options. One, you can stop valganciclovir for a week and check the ALT again. If that is coming down, you'll know it is due to the valganciclovir. Or if you have done a viral load and the viral load is coming down, which means valganciclovir is working, which means the ALT from the disease itself should come down, but yet the ALT is going up, you will know then it's from valganciclovir. That is what we found out as a rule of thumb, or from a clinical practice. This is how you diagnose or you differentiate whether it is a medication-associated hepatic enzyme rise or whether it is a disease-associated rise. Is it clear?
Yeah.
Good. So valganciclovir is not used anymore, and it is only reserved for people who cannot tolerate oral valganciclovir, which is very, very, very rare. It is very well tolerated. And then we've got two other medications, Foscarnet and maribavir, for this CMV that we had, which was quite a difficult one. This baby had a genetic mutant variety which was resistant to this drug valganciclovir. So we had to give them Foscarnet, which is usually given for 8 weeks, but it needs a central line for that. And we monitored this LFT usernese and viral load. And after 8 weeks, we could switch over to oral valganciclovir. The main toxicity, as we know, is Foscarnet is nephrotoxicity, which is for we need regular renal markers with pre and post hydration after giving the medication. There is another drug, maribavir, which is in the market at the moment, but it is not known to known to use in newborn. It is mainly used for CMV post-transplant, but it is available for pediatric use, but not for neonatal use as of now. But probably down the line, it will come up. The neonatal safety profile will come up as well. This is more or less the algorithm, which I don't need to go through, discuss. I think this probably is an important MBT management. The three factors which probably has to be, the three people who have to be involved is an ophthalmologist, an audiologist, and a radiologist, basically. So that's your MBT team to start with. And then you go on to, as he goes into the community, with physiotherapy, occupational therapy, and then infectious disease specialists. So those are the main areas which probably will need an ophthalmology referral. If CMV positive, you have to refer immediately, examine in 3 weeks, and then thereafter regular. And then I've already dealt quite a detailed about how do you do hearing test, the first and second hearing test, what's the difference and how do you treat. And then radiology, we went through, we said that as calcification to start with on an ultrasound scan is the first screening mode, but thereafter MRI is the best diagnostic mode to predict long-term sequelae. And that is your MDT, how you approach. So the hearing test person has picked this up now. Now what does he do? The second hearing test has no clear response. That's what you should do. A saliva should be sent at that point, or a urine should be sent at that point, and then you get all these specialties involved. So this is if your hearing screen fails, and this is how you get the team involved with different specialties. However, if it's the other way around, if it's an antenatal or neonatal concern of CMV, we send a saliva straight away from there, or a urine, and then if that is negative, it's heart and well and good. If it is positive, then the neonatologist gets in touch with the audiologist, ophthalmologist, infectious disease, radiologist, and does the proper investigations, and then refers to the ID consultant, and then we can think about treatment. As we said, asymptomatic babies can become symptomatic later, so audiology follow-up is recurrent, should be till about 5 to 6 years of life, and ophthalmologic assessment should be regular as well. So if you're getting a take-home message, we know it's the commonest hidden burden. Difficulty in differentiating CCMV from maternal and acquired, and there is no proper biochemical marker to prognosticate this disease as of now. But the most important thing, if you take home something, if a baby has failed a newborn hearing test on 2 occasions, the primary and the secondary should get tested for CCMV. I think this is the main area. This is the, if you take one message from this talk, that should be a failing newborn hearing test should go for a CCMV. PCR is the gold standard, and either urine or saliva. Do in either. If you can catch a good clear urine, fair enough. Otherwise, go for a saliva if you have the facilities. Treatment indicated, parents should be on board, 6 months treatment, hearing screen, and multidisciplinary care. Thank you, guys.
Thank you, Bivan, for a very informative speech. Thanks a lot. Thank you.
Are we taking any questions from the audience? Anyone has anything to ask?
So just to end the session, if any question, we can speak, we can get back to Bivan. And lastly, prevention is the best thing. So prevent CMV by sanitization, hand washing, give antiviral drugs to the mother if they're having CMV infection, and vaccines are upcoming in vogue. Thank you.
So thank you very much, Dr. Bibhan Shah and Dr. Shantanu Ray. And now we proceed to the next session, which is infections in nephrotic syndrome. And for this, I would like to invite Dr. Amitabh Pahari sir, and the expert would be Dr. Ognishekar Shah. So over to you, sir.
Good afternoon. Thank you for inviting me for this Paed Connect, and Dr. Atanu Bhadra in particular. It's a great opportunity to come and talk in front of you about a subject which is very close to my heart. Being a simple pediatrician with a dual head of nephrology and infectious disease, where I have got some experience in both these specialties, I think this is one of the topics which is very close to my heart, and I have got some experience about it. What I'm going to do today is actually discuss not infections in nephrotic syndrome. I'm going to discuss infection and nephrotic syndrome, because all we know, nephrotic syndrome is an immune deficient state by itself. Infectious episodes in nephrotic syndrome is responsible for this high morbidity and mortality, and also dictates that whether it will be responding to steroids and whether there will be relapses which might be initiated by the nephrotic syndrome. And it may cause steroid resistance in the presence of infection. Type of infection is very important from the therapeutic point of view and to also to establish preventive measures. Now, nephrotic syndrome and infection is very intricately related in every aspect. Infection has been postulated in the etiopathogenesis. Also, during the initial episode, like most of the children with initial episode, at least 2/3 of them come up with a viral infection. Viral infection and other infection often potentiates them for a relapse. Infection is one of the most common complications of nephrotic syndrome. We need to learn as a pediatrician about how to prevent infection in nephrotic syndrome, that way altering the outcome. বাংলায় একটা কথা আছে না, ইনফেকশন আর নেফ্রোটিক সিনড্রোম ওতপ্রোতভাবে জড়িয়ে আছে অঙ্গাঙ্গিকভাবে একে অপরের সঙ্গে, and we need to really identify every aspect of this infection and nephrotic syndrome to manage children with nephrotic syndrome in its best possible manner. So just a brief touch about etiopathogenesis of nephrotic syndrome. This is GBM. This is the endothelial cell with holes with fenestration and epithelial foot processes where effacement of those might be actually giving rise to massive proteinuria. Core particular etiopathogenesis has been always been discussed with immune dysregulation, particularly T cell dysfunction, cytokine bias, circulating permeability factor, all of them giving rise to podocytopathy, which might be genetic in some steroid resistant cases, but most of the minimal change disease and steroid sensitive cases, it's actually immune mediated injury of the basement membrane. So infective agents like viruses has been postulated as causing podocytopathy, particularly in genetically predisposed individual, and they are subject of future research. Common viruses that has been implicated at the initial episode of nephrotic syndrome are actually all the common viruses that we come across in our day-to-day basis, including polyomavirus SV40, which has been found to be one of important cause of FSGS. Now, this is actually, AI generated image that I have actually learned from a lot of my residents and created one from my five previous slides that I have discussed. So viral or bacterial infection giving rise to immune activation, thereby giving rise to immune dysregulation and circulation of IL-13, IL-8, and super and T cell and cytokine storm. And these cytokines are actually increasing circulatory permeability factor, giving rise to podocyte injury, podocytopathy, massive proteinuria. That's actually basic role of infection in the etiopathogenesis of nephrotic syndrome. And this is an area of intense research. And a few years time, you never know the way we have actually come across in our days of training. Peptic ulcer disease is actually being treated by even surgically by gastrojejunostomy and vagotomy, has subsequently been totally forgotten, and we all know H. pylori treatment can get us rid of peptic ulcer disease. Maybe in the future certain infections might be actually manipulated in a manner that nephrotic syndrome might be treated differently rather than by the immunosuppressive treatment that we are doing today. So what is the treatment of nephrotic syndrome now? We all know that nephrotic syndrome is being treated with corticosteroids, and it's very important to screen for infection before treatment. Take a detailed history of previous infection as well as immunization. Test for tuberculosis has been recommended by ISPN guideline, particularly the Mantoux test. And if suspected, chest X-ray. Also test for hepatitis B if the vaccination status is not known, and sometimes in special situations for both HIV and hepatitis C as well. So this is the approach to first episode of nephrotic syndrome: 6 weeks of daily steroids and 6 weeks of alternative steroid. If 6 weeks of daily steroids is not responding, we are labeling that as steroid resistant nephrotic syndrome, and that is being referred to a pediatric nephrologist. Otherwise, most of the time, pediatricians are supposed to actually, take charge of the management of this child. Coming to steroid sparing agent and approach to FRNS as SDNS, there is actually, depending on the steroid threshold, if it is more than 1 milligram per kg on alternate days, you are actually, going to mycophenolate, mofetil and cyclophosphamide. If it is less than 1 milligram per kg per day and there is no significant steroid toxicity, then you are thinking of giving levamisole and MMF. But obviously, if they're still difficult to treat disease, you are thinking about starting on CNI like cyclosporin and tacrolimus as well as rituximab. The reason I am saying this because all these gamut of medications and their side effects, you have to realize all of them are actually very significant immunosuppression medication and give rise to very serious bacterial infections at times. The more you go down the line up to rituximab, you will find the infection rates are also actually going higher and higher. And all this is actually making our nephrotic syndrome children a complicated one. Infection is one of the most common complications of nephrotic syndrome. Hypovolemia again, the complication of nephrotic syndrome, which is much more prevalent when the child has got infection. Thrombotic episode like thromboembolism and pulmonary embolism also more likely in a child with infection. Dyslipidemia, side effects of treatment means more infections because immunosuppressive medications are being used. And all children with frequent relapse, steroid dependence, particularly steroid resistant, are actually much more prone to develop serious infections needing hospitalization. So why nephrotic syndrome are more prone to infections? There is reduced immunoglobulin, not because they're losing the immunoglobulin in the urine, but often the production in the liver is also affected. There is reduced complement and troponin factor B. There is altered T cell function. Obviously, immunosuppressive therapy that we are giving to treat and cure them from nephrotic syndrome is also going to give rise to significant infective risk. And presence of edema and waterlogged tissue often kind of you as a rich culture media for harboring infection. So what are the common infection? Relapsed nephrotic syndrome is 50% of them are associated with upper respiratory tract infection and GIT infection. 50 to 70% of relapses among children in developing countries chiefly follow viral upper respiratory infection. Common infections like acute upper and lower respiratory tract infections, skin infections, acute gastroenteritis or dysentery, urinary tract infection, but more importantly, spontaneous bacterial primary peritonitis is something that we are always bit worried about any child with nephrotic syndrome presenting with abdominal pain, with or without fever, and maybe a bit unwell. So common infections like viruses, pneumococcus, gram-negative organism, streptophilococcus, as well as fungal infection like Candida aspergillus should be actually considered in any child with nephrotic syndrome developing features of infection. And we have to actually use a very high index of suspicion. Major infections in nephrotic syndrome is about 20 to 38%. Minor infections, if you consider, it's actually 76 to 84% of children is actually harboring that. And any child with infection in nephrotic syndrome might have just proteinuria without developing into relapse. Treat infection first. That should be actually the guideline, because that way you might be actually just don't need to start on a higher dose of steroids, which might give rise to significant steroid cumulative toxicity. Management of infection in nephrotic syndrome actually need a high index of suspicion, because early diagnosis is very important. Careful clinical review of the history and investigation. There is pitfalls. CRP might be borderline high. CRP might not show a very high result. High white cell count might be a reflection of just using steroids. Procalcitonin might be very low because the child is already on steroids. So you have to actually use your clinical judgment, and early intervention should be actually done so that prevention of severe complication can be avoided. Your initial empiric antibiotics should be covering pneumococcus as well as gram-negative organism, and you should always give stress dose of steroids. If the child is on full dose of steroid, you should be stopping and starting this stress dose of steroids. If the child is not taking oral, give IV hydrocortisone. Otherwise, you can even give oral prednisolone at 0.5 milligram per kg per day. But give it in 3-4 divided doses rather than once or twice daily, because that's the dictum for stress dose. closely monitor the fluid status of vital, because simple infection might be simple in an immunocompetent child, but immunocompromised state like nephrotic syndrome, the same infection might give rise to devastating results. And always think about giving stress dose of steroids as part of, particularly if they are actually, even if they are not on steroids, if they have received more than 2 milligram per kg per day for in last 1 year, more than 2 weeks. The short course daily steroids during infection has not shown to be validated by Prednos 2 study done in the UK, but in most of our Indian authorities as well as Sri Lanka and other Asian countries did suggest to give a short course of steroids with between 0.5 to 1 milligram per kg for a week to see whether treating the infection and giving the stress dose of steroids can actually prevent the true relapse. More importantly, if the child is on alternate day steroids, if the child is developing proteinuria in association with steroids, make it daily for 1 week. This is something I actually recommend all the pediatricians that who send me patients with nephrotic syndrome to follow, that they can do themselves. Starting a child with respiratory tract infection with an antibiotic like azithromycin, coamexacar, but also 10 milligram alternate day, the child was actually on steroids at that time. Please make it 10 milligram once day for at least 1 week and see what's the response. Number of these children, at least 2/3 of them, might not be needing full-blown treatment for relapse if you follow this principle. Prevention, I think policy on immunization in nephrotic syndrome is very straightforward, but everyone starting treatment with steroids in a child with nephrotic syndrome must review vaccination details before embarking on therapy. Patients on prednisolone more than 2 milligram per kg per day, total 20 milligram per day, if it is more than 2 weeks, are supposed to be immunocompromised, and they should not be given a live attenuated vaccine. But all inactivated or killed vaccines are safe. Live vaccines should be given only when they are off steroids for at least 4 weeks. If there is a pressing need, may be given to patients on alternate day prednisolone when they are less than 0.5 milligram per kg. Review vaccination details before embarking on therapy. Pneumococcal vaccination in all children with nephrotic syndrome during remission and off steroids. Varicella, hepatitis B, H1N1, meningococcal disease during remission and off steroids should be given. Annual flu vaccine is recommended for all. Catch-up immunization in remission is very, very important. So whenever a child actually go into, even after first episode, they go into remission, I send them to the general pediatrician to catch up immunization after 1 month, because otherwise a lot of these children after 5-6 years down the line, they will come back to us saying that, oh, we have not completed even our primary immunization schedule. And vaccine associated relapse is a definitive thing that has been recommended with both DTP as well as flu vaccine. After you give vaccine, like the way infection often potentiates a relapse, vaccine can also potentiate. But we should not be actually, be worried about that. We should still continue to give immunization to these highly at-risk children. Post-exposure varicella is particularly very important. If susceptible patient not immunized for varicella, ideally should be giving varicella zoster immunoglobulin. But if varicella zoster immunoglobulin is not available, which is often the case, please treat with oral acyclovir within 7 to 10 days of exposure. And if the child is coming to you within 5 to 7 days of exposure and off steroids for 4 weeks, you can give even the vaccine. Outcome of nephrotic syndrome largely depends on presence of infection. Relapse-specific interventions contribute to significant reduction in disease morbidity from renal and infection point of view. Overall, long-term prognosis continue to remain good. More than 95% survival in a 17-year follow-up study, which is very encouraging. 2 to 5% long-term mortality, mostly in SRNS and ESRD. Infection-associated morbidity and hospital admission continue to be a major concern, more so in a developing country like ours, because 60 to 70% death in children in nephrotic syndrome is not because of the kidney-associated injury, but because of infection. And all pediatricians like us has got a role for prevent early diagnosis and treatment so that that can be prevented as much as possible. Thank you for your kind and patient hearing. Before I conclude, I invite you all to please join the ABC Children's Conclave, which is being done in association with West Bengal Academy of Pediatrics and in collaboration with Boston Children's Hospital by Apollo Children's in Hyatt Regency between 8th, 9th and May of 2026. We heartily welcome and thanks a lot for everyone who have already registered. Thanks the whole organizing team for giving me this opportunity to talk here in front of us on a subject which is very close to my heart. Thank you, Dr. Upni.
Thank you, Parida. For the conclave, we'll be, distributing some flyers for those of you who have not registered yet. I'll be circulating them actually. One or two words about infection in Parida. What is your stand on this, URTI, nephrotic syndrome, 5 days of short course, 0.5 milligram? There is some confusion that is it on, off, what should we do?
The Paed study that has been done, which is actually quite a large prospective study that was published in the UK Paed 2, they have found that there is not much of benefit. But the study that has been done in Sri Lanka as well as AIIMS New Delhi, they have said during upper respiratory tract infection, particularly children who are already on steroids, say alternate day, it should be made daily. And maybe it's not going to do any harm if you give 0.5 milligram per kg for 5 to 7 days. When they are actually having upper respiratory tract infection and continue with the current steroid regime, they're saying. So the bottom line is, I actually give. If they are alternate day steroids, I make it daily. If they're not on alternate day steroids, it will be individual merit. If it is just a simple viral upper respiratory tract infection, I often do it if they're off steroids only for a few months, because they are still going to need a stress dose of steroids anyway. So it's not going to do any harm.
So you still give?
Yeah, I did.
Right. Thank you. As an intensivist, if a nephrotic syndrome kid becomes septic and bad, treating a immunosuppressed patient with multi-organ failure sepsis is the holy grail of intensive care. That's the most difficult patient. A immunosuppressed patient, sepsis, multi-organ failure, most difficult patient. So best not to reach there. So best to treat them early so that they don't go to sepsis. So over treat them, that's okay. And one thing, varicella VZIC is often not available. If you do not have VZIC, but you've got a patient with nephrotic syndrome who have been exposed to varicella, you can give IVIG.
Yeah, that's another thing. You can give a 400 milligram per kg per dose instead of.
Yeah, and IVIG is available. VZIC is not available for a long time, but we often face that. A patient who's been has been exposed, IVIG will do as well. Thank you.
Thank you very much.
Question.
Microphone.
So we go to the last topic, which is just like fever keeps on revisiting the children. So now Dr. Shumon Poddar is going to revisit fever. And so at the lead expert here will be Dr. Shomik Hajra. So on to the next session, please, Dr. Shumon. And to make an announcement that on 12th of July, we are from New Kolkata Academy of Pediatricians, we are holding a one-day conference, which is Office Con, which is related to your office practice CME. We have all the common topics that you face in the OPD. So do register, and the registrations are open, and there will be a very good faculty, star faculty, which national and local. So you will miss if you don't register soon. So on to you, Shumon.
Okay.
Yes, sir.
Good afternoon, everybody. Thank you for the honor to be here. Especially, it is very difficult after Vivanda, who happens to be my senior in North Bengal Medical College, to speak and also to speak after Pahari sir. So, regards to my seniors, love to my juniors and the batchmates. And it is a little easy when your friend is your chairperson. So we have been in touch when we were not known to others. So since then we know each other. Now, this little technical glitch, they are solving it. Till then, I'm supposed to talk on fever. Now, when Atanoda said, you have to talk on fever and paracetamol, and that too for 15 minutes, I was thinking, what could be the topic? What is to say about fever? It's such a broad thing, and what to say, how to continue. Then I thought that in day to day practice, we sometimes forget the basics of fever. So I'll try to keep myself in the basics. And sometimes we do get across something which is beyond basic. So I will be presenting one or two cases like that, which are beyond common fever. So fever revisited. So I'll be visiting fever. I'll be visiting fever as you see that what is fever? So let's come to the basic. What is fever? Now it is whenever we say fever that it is beyond the baseline of temperature, and that is this 38 degrees centigrade. Now this 38 degrees centigrade, then comes the question, which temperature? Oral temperature, armpit temperature, rectal temperature, what is it all about? But this is the definition that I have quoted from Mayo's Clinic. According to them, whatever and wherever I have seen the definition of fever, it is saying that the core temperature. So it is rather a It's not a disease, it's rather a symptom. So fever per se is not a disease, it's a symptom that we need to address. So when we say fever, the first thing that comes, ডাক্তারবাবু হাত দিয়ে দেখেছি জ্বর আছে। ভেরি ডিফিকাল্ট। হাত দিয়ে দেখেছি জ্বর আছে, ভাই তোমার হাতটা ঠান্ডা হলে তাহলে কি হবে? রান্নাঘর থেকে এসে ধরছো তাহলে কি হবে? So there should not be any relative term. I usually talk to my patients that what is the time right now? Can anyone say? What is the time? Immediately we look into the watch. Exactly, I do the same thing in my chamber. Whenever I ask, what is the time now? They immediately start searching either mobile or the watch. So immediately I said, see, if you are wrong by 5 minutes right now, it's not going to cause any harm. But if you are wrong by saying what is the actual temperature, whether it is 100, 101 or it is 103, 104, then it is a dicey thing. So it is always better to have the temperature to be recorded. And while recording, we have plenty of options. We have oral, rectal, ear temperature, forehead temperature, and so on. But for all practical purpose, in this part of the country, we use this armpit temperature. However, in case of NICU, if doable, rectal temperature better denotes the core temperature of the newborn. Now, what is the mechanism? We all know that hypothalamus is the body's thermostat. Now, it sets a temperature set point in response to something that is called as pyrogen, which comes either from the immune system that is combating with the germs, or it comes from the particular organism which has invaded your system, or maybe some inflammation that has give rise to this pyrogen. So in response to it, the hypothalamus set a temperature that is beyond the normal, then it is causing the fever. And to achieve that set point, either you will be having vasoconstriction or you will be having shivering. That's why some people say we are feeling chill, we are feeling some rigor. So this happens because of that. Now, why this extra set point is given? Now again, whenever you serve a food, unless it is a frozen one or ice cream like that, it is always better to warm the food. Why do we warm it? Not just because of taste, but because to kill the organisms that might be hovering in your food. Exactly in a similar tune, the body is set in a different set point so that the immune system will work little better, but the organisms will not have the privilege to rapidly multiply as it can in the physiological temperature. So fever is not always bad. Then the question comes, ডাক্তার হালকা জ্বর আসছে, একটু জ্বর জ্বর ভাব, হালকা জ্বর, মিঠা মিঠা বুখার आ रहा है. I don't know what is মিঠা মিঠা বুখার. How a fever can be so sweet. So what is low grade versus high grade fever? Again, no unanimous decision or definition is there. I have quoted two such. One is from the Mayo's Clinic, another is from NIH. For all practical purpose, what we say, till 100, 101, it is low grade. Beyond 101, it is possibly high grade. That is for all practical purpose that we can say. And this is the quotes that I have taken. The left-hand side on your screen is from the Mayo's Clinic, the right-hand side from the NIH. Now, this needs to be differentiated from hyperthermia. Hyperthermia is something beyond normal fever. This is when the temperature is 41 degrees centigrade or beyond, then it is called as hyperthermia. So that is what you need to differentiate. When it is fever, the hypothalamus is still the boss. It is setting a set point and it is manipulating your immune system to some extent. So it is still under the control of the hypothalamus. But when it is hyperthermia, it is beyond the control. There, it is beyond the confines of the set point temperature and regulation of the hypothalamus. So it has to be differentiated from normal fever. But for all practical purpose, we usually say hyperthermia and fever in a synonymous way. But in a true sense, these two are different. Then comes, I remember my MBBS days. It was possibly third year when I was asked, how many types of fever do you know? I said, I know only one fever, জ্বর আসে জ্বর হয়. So that was what খুব বেশি পড়াশোনা করতাম না বিবান্ধার মতো. So anyway, so what are the fever by pattern? Continuous fever, when the temperature remains above the normal throughout the day, not touching the baseline, and the fluctuation is less than 1 degree centigrade, then it is continuous fever. This is something like that, and typhoid, pneumonia, these are the things. Then comes remittent fever. Here, the temperature is not coming to the baseline, but the fluctuation is little bigger. Here, the fluctuation is more than 1 degree centigrade. It can be infective endocarditis, certain viral infections maybe even in dengue. Then the intermittent fever. Here, the fever present for some hours, then normal temperature intervening. You can see the normal temperature, but the fever is coming every day, maybe 2 or 3 times a day, with the baseline touching in between. So this is intermittent fever. When it is a daily basis, it is called quotidian. It can be tertian or quatern based on 2 days or 3 days cycle. That is, the classical example is malaria. Then a loose term, hectic rise of temperature. So I searched what is called hectic rise of temperature. Yes, this is called the wide fluctuation. That means the baseline is touching, the fluctuation is very high, the sky high temperature, then coming down beyond 2 degrees centigrade. Then it is called as hectic rise of temperature. And the classical example is in case of abscess, you can have that. Even in case of severe sepsis, you might have it. Then the question comes, step ladder. Step ladder, সিঁড়ির মতো ধাপে ধাপে উঠছে. Nowadays, we don't see step ladder pattern for maybe innumerable causes, but the classical example of step ladder pattern is typhoid or enteric fever. It gradually, day by day, it increases, ups and downs, ups and downs, ups and downs. So gradually increases, just like the step of a ladder. Previously, this classical scenario was better seen in typhoid. Next comes biphasic. So yes, biphasic or saddleback. Single entity, 2 episodes of fever. That means you have a day or 2 of fever, then you have a gap of maybe few days, 4 days or 5 days or maybe 3 days. Then again there is fever coming back. It's the same entity, same reason, but second episode. The very common thing is dengue. So saddleback or biphasic fever. Then recurrent fever. ডাক্তারবাবু আমার বাচ্চার এত জ্বর হচ্ছে, খালি জ্বর হয়, ঘন ঘন জ্বর হয়. So what is recurrent fever? Then recurrent fever classically can be of 3 types. It can be relapsing, relapsing, and periodic. Now relapsing fever, here there are fever episodes and afebrile several days, usually 2 to 3 weeks in between. So then it is called as relapsing fever. Then relapsing, 1 or 2 weeks of fever, then 1 or 2 weeks of no fever, again 1 or 2 weeks of fever. The classical example is Hodgkin's lymphoma. Then the periodic fever. Fever periodically coming at maybe few weeks interval with some ulcers maybe, that is PFA-PA. Periodic fever, aphthous stomatitis, pharyngitis, adenitis. Classical example, PFA-PA. So these are the conditions where you can have recurrent fever. Then you can differentiate fever by duration. Less than 7 days acute, 7 to 4 days subacute, and chronic if it is more than 14 days. Okay. Then what is PUO? If it is beyond 3 weeks and you have done all possible practical tests, but you have not identified the cause, then it is PUO. And PUO is something, a nightmare of ID sections, because sometimes very, very common things may present as PUO. Even TB may present as PUO. Then types of, based on the cause, infectious, non-infectious. We all know that there are innumerable causes. So I'll not go into the details. It can be malaria, typhoid from the infectious segment, from the non-infectious segment. It can be malignancy. It can be some other reasons, maybe sogia. So whatever, there are innumerable causes. So let's see this one. A child newborn, 2 days of fever for 2 days, only in the afternoon. Cry reflex activity normal, anterior functionally fat, capillary refilling time less than 3 seconds, no evidence of sepsis, sucking well, otherwise playful. Little urine output is little less. So what could be the possibility? What could be the possibility? Yes, I can see a lot of PGs here. What could be the possibility? তোদের তো সবার NIC হয়ে গেছে। This is possibly environmental cause, dehydration fever. Maybe environmental cause. Nowadays, when there's scorching summer, people used to think that AC চালালে fan চালালে বাচ্চা ঠান্ডা হয়ে যাবে। So I always say keep that temperature at a comfortable tune so that the palms, sole, and the abdomen of the baby, of the newborn, should remain just warm. So we will not decide at what temperature the child will stay. The child itself or the newborn itself will decide at what temperature the newborn will stay. So based on that, you can prevent this sort of thing. Otherwise, temperature at this age is definitely alarming. Now, look at this case very carefully. This is a case that I have faced in ICH in 2017. 7-year-old girl, recurrent headache, usually on one side, aggravates on bright sunlight, family history of migraine in mother. Diagnosed as childhood migraine in Kolkata, treated initially with flunarizine. Not much relief, so second opinion has to be taken. So Bangali Tirthoketra hoy Vellore noy Chennai. So they have reached to Chennai Apollo. There, in December 2016, look at the time frame. December 2016, they have reached Chennai Apollo. After a lot of investigation and all this, they landed up to the same diagnosis of childhood migraine. And now the consultant over there has prescribed topiramate, and there is well relief. Okay, so better control of migraine. So Chennai ডাক্তাররা বেশি ভালো. Now, I am seeing the child in April 2017. The child presented with history of high fever for 1 month. High fever, not low grade. High fever for 1 month. Fever comes only in the daytime, afebrile at night, no localizing sign, no weight loss, and they have come with loads of investigation. Believe me, it was like this. Loads of investigations, all normal, and TB ruled out. With all possible way, TB ruled out. Then this is the history that I got. Whenever she goes outside, the temperature becomes so high that she has to wrap herself with wet towel. This was the history given by the mother, and to take paracetamol sometimes. In fact, they reached ICH with a towel in their hand. So a 7-year girl coming with a towel in the hand with so much of big history sheets and all this. So what could be the possibility? Sir, ectodermal dysplasia at 7 years is very unlikely to diagnose, and this too has started for 1 month only. Exactly. Then on further query, we find out that the child does not sweat now. The child was prescribed in December, that was winter month. So that child doesn't face any problem initially. Then when the summer came, and the child has actually came from Purulia, so scorching heat. So they said that now the child doesn't sweat. And when we admitted the child and kept in EC, no fever at all. So it was actually topiramate induced hypothermia due to hypohidrosis. So drug induced. Now, when we say treatment of fever, So what is the treatment of fever? As I started, that fever is not always harmful. Sometimes it gives some benefit, because by reducing the fever forcibly, you are not helping the kid in any way. Then why do we prescribe antipyretic? We prescribe antipyretic to give some comfort to the child, not to give any benefit to the child, to give some comfort to the child. So do not try to reduce the temperature forcefully. Try to deal with the cause. So adequate hydration, maybe ORS or homemade fluids, light clothing, lukewarm sponging, but always avoid cold water. Why? If you are giving cold water, then there will be sudden drop in the surface temperature, but not the core temperature. So there will be wide difference between the core temperature and the surface temperature. So what will happen? It will be rebound fever, and there will be huge shivering that is in fact more detrimental to health. The child will be more exhausted. So that is not correct. So it is always to get rid of the fever gradually down. So tepid sponging and rest, definitely. Then what are the drugs? First line, definitely paracetamol. We all know the dose. Next, you may prescribe ibuprofen. Now, writing ibuprofen, you should have some responsibility for that. Because ibuprofen in case of dehydration, ibuprofen in case of dengue, it can be definitely disastrous, especially in the background of renal disease. It can lead to acute tubular necrosis, and mind it, that is irreversible. So, since this ibuprofen is written in the textbook of Nelson, but in our country, for all practical purpose, it is better to avoid ibuprofen, because you don't know which fever is because of dengue. And there is no recommendation of combination, neither ibuprofen paracetamol nor mefenamic acid paracetamol. There is no such recommendation. Then, as I said, treatment of the cause. Get rid of the cause, fever will go away on its own. So fever is not synonymous with ceftriaxone deficiency. This is a common term sometimes we use in our day-to-day round in ICH. So it is not a synonymous with ceftriaxone deficiency. Try to find out the cause. Now is another case. This case is now admitted in ICH. 3-year-old boy, known case of seizure disorder with Dravet syndrome, on valproate, lacosamide, topiramate. Plenty of times different anticonvulsants are changed. Admitted with history of low-grade fever for 4 weeks. Hemoglobin low, otherwise CBC, CRP normal, chest X-ray, USG more or less normal. No focus found, TB ruled out. There was definitely weight loss was there, but the child is a CP child, so we don't expect normal weight in them. Kept under observation at hospital, and then there is sudden rise of temperature with cold and cough, found out to be influenza. It was, I don't remember, possibly H1N1 or H2N2, something like that. And likely it was hospital acquired. So treated with oseltamivir, the child improved, but again stuck to low-grade temperature. Admitted with low-grade temperature for 4 weeks, got admitted, during investigation acquired this flu, treated, again landed up in low-grade temperature. Again fever started becoming high with new onset cough, high counts, high CRP, treated as secondary bacterial respiratory infection, successfully treated, but again going back to low-grade temperature. So again low-grade temperature. By the time we have ruled out all these rheumatologic causes, Dr. Priyankar Pal has seen this child, and we have ruled out successfully. Still low-grade fever persisting even after 1 month of hospital stay. Still the child is admitted in ICH. So what is the case then? Is again the topiramate culprit? But now the child is now that, but the two cases are separate. One is in 2016-17 and now is in 2026. Definitely. Now now baby is in AC and also stopped the topiramate. Still low-grade temperature persisted. Valproate and possibly now lacosamide or something like this, but topiramate was omitted. still fever is persisting. It was actually neurogenic fever, which is a diagnosis of exclusion. We don't have much thing to do. We may apply baclofen, you may apply propranolol, but not of much relief. We don't have something to do. Now we are waiting for the parents to understand that this is neurogenic fever. We don't have much to offer to the child. Just maintain the temperature in a newer set point. So now comes paracetamol. জ্বর কমছে না, ডোজটা বাড়িয়ে দিয়েছে ডাক্তারবাবু beyond 15 milligram. Someone even gives 30 milligram per kg. Very difficult. And remember, paracetamol toxicity can happen by staggering dose of paracetamol as well. 2 ঘন্টার মধ্যে জ্বর এসছে, আবার দিয়ে দিয়েছি. So paracetamol toxicity we need to keep in mind. Drop versus syrup. Again, the dose is different. So be careful. Paracetamol normally broken down safely, and in overdose, it is excess is converted to NAPQI, that is N-acetyl P-benzoquinolamine, which is degraded, which depletes the glutathione. So this is anticonvulsant, antioxidant, and then there is hepatocellular necrosis. But when there is toxic dose, either a single toxic dose or cumulative toxic dose in a short span of time, then it is beyond control of the liver. Then you may land up in hepatocellular failure. But problem is, it will not manifest in the first day or second day. First 24 hours, nothing might happen. Nothing. General malaise, nausea, vomiting, all non-specific. Minimal signs, normal liver enzymes, nothing will be there. In the next 24 to 48 hours, or maybe 72 hours, there might be some evidence of hepatotoxicity, liver enzymes, plus minus, maybe raised, maybe right upper quadrant pain, PTAPTT may start rising, but after that, in 3 to 4 days' time, hepatic failure with encephalopathy may set in all these features of metabolic acidosis, coagulopathy, jaundice, vomiting, and whatnot. So multi-organ failure may set in 96 hours' time. The child may thrive by 4 days' time. What should be the regime? If you have time, that within 1 hour or 2 hours the child has come to your ER, then you can use activated charcoal, you can do the stomach wash. N-acetylcysteine is the main part of the therapy, acts as a life-saving antidote. This replenishes this glutathione. But in case of fulminant liver failure, liver transplant may be needed. I remember very recently one such case admitted in Apollo. Chandri and Ognita must be knowing. In the recent, maybe in last 3 to 4 months' time, there was inadvertently taken high dose of paracetamol, and the child admitted in Apollo then shifted for possible liver transplantation. I lost to follow up after that. That child came from Behala. Big adolescent race. And that maybe you might be knowing that. So yes, so that can be huge catastrophe like that. So it is not very rare. Even if you have slightest suspicion that there is some overdose, some sort of maybe PCM toxicity, it is always better to admit the child and have the child under observation for at least 3 to 4 days. So the take-home message is, fever is a symptom, not a disease. And do not try to put down the fever forcibly. As I say, get rid of the cause, the disease, the symptom will go away. So treat the cause, not just the symptom. And again, I repeat, fever is not synonymous with ceftriaxone deficiency. Thank you.
That was excellent. I think Mrinalda has got some questions. Okay. So
parents usually want to reduce the fever. আমরা যেটা বলছি শুনছে না। at short interval যে ওরা আবার রিপিট করছে, দ্যাট ইজ এ বার্নিং প্রবলেম আমরা ফেস করছি। প্রথম ডোজ দিল, কমছে না, 2 ঘন্টা 2.5 ঘন্টা সেকেন্ড ডোজ দিয়ে দিল একটা পরপর, কারণ ওদের কিছুতেই বোঝানো যাচ্ছে না যে ওষুধটা অ্যাবজর্ব হবে, একসময় শুনছে না। তারপর যা লিখছি তার থেকে বেশি। সেখানে একটা মজার জিনিস দেখছি, জ্বর কমছে না যখন 3rd ডে 4th ডেতে ইউরিন টেস্ট করছি, দেখছি যে ইউরিনে অ্যাসিটন পাচ্ছি। এইটা একটা দেখছি, হাউসকে আমার এইটা জানা, আপনারা এরা পেয়েছেন কিনা। 3rd 4th ডে হাই ডোজ দেওয়ার পর ইউরিন রুটিন করলে যে কিছু আছে কিনা দেখবে অ্যাসিটন প্লাস। এইটা একটু জানতে চাইছি, ওয়াই অ্যাসিটন ইজ ইউরিন আসছে কেন?
Shomek, will you address or should I? Acetone plus, or better to say ketone bodies. It is actually when the body is burning your fuel in alternative pathway. So that indicates that the hydration status plus minus, but your body fuel is burning. That means the child is not having enough of calorie. So alternative pathway is getting activated, so ketone bodies are coming. It's nothing related to this paracetamol or all this. And regarding, as you said, that paracetamol overdosing and all this, always that's why I just said, within a short span of time, if the total dose is more than 150 milligram per kg per day, then it is difficult. It can be a paracetamol toxicity.
There is one, not a question. I'll ask your opinion. Every brand of paracetamol comes up with every sort of concentration package.
Right.
So what is your take on having a drop, having a 120 milligram per 5 ml syrup, 250 milligram per 5 ml syrup, 500 milligram per 5 ml syrup? Because over the years, what we have seen is most of this inadvertent paracetamol toxicity is because a doctor has said XYZ drop 1 ml or XYZ syrup 1 ml and somebody has given XYZ drop 1 ml, which is 5 times the concentration almost, at least 4 times the concentration. And then 6 hours you keep 4 times the concentration, so the cumulative is more than 10 times.
Right.
What is your take on this?
Yeah, very true. For that, I think for this paracetamol, at least we should have some legislation. And I think there should be single concentration, maybe something in between, whatever suits the brand, maybe 100 milligram per ml. If that is made standard and that is only one available, then this sort of confusion will not be there. So this, I don't know, either from the government aspect or from national bodies like IAP, there should be some move that we have already done in case of ORS. So maybe at some day, some of us will move for this, and that day we will get rid of it.
I think so. I think this confusion needs to be clear.
Solved, yes. Yes.
জানতে চাইছি যে যখন দেওয়া হচ্ছে আমরা ইউজুয়াল ডোজ দিচ্ছি, প্যারেন্টস বলছে যে ডাক্তার ওই খাই দিলাম বন্ধ করে দিচ্ছে, তারপর বললো আমরা অন্য একটা চেঞ্জ করে অন্য ব্র্যান্ড এনেছি ওটা খাই দিলাম, ওটাও রাখছে না, যতবার দিচ্ছি তত বড়। সেখানে কি আমরা ইন সাপোজিটর ফর্মে দিতে পারি এই বাচ্চাগুলো যারা রিফিউজ করছে?
Yes, you can.
অ্যাকসেপ্ট করছে না।
Yes, you can, provided it is available. It is mostly not available. But remember one thing, IV paracetamol should be as less as possible. Try to shift to oral form as early as possible because IV paracetamol is arrhythmogenic.
This is not IV paracetamol, because the battery is high hospital stock.
Very true, very true.
And there is not much of an advantage because paracetamol has got an excellent oral bioavailability.
Very
true. So anybody who can take orally should get a oral paracetamol. It's only for unconscious individuals who cannot take anything orally who can consider an IV preparation.
Absolutely correct.
What are the problem? Yeah. So thank you very much, Dr. Shumon, Dr. Shomik, for a wonderful talk. And I would now request Dr. Shubhashish Bhattacharya to just sum up in a very few words.
Thank you for inviting me. Just only mention because all of the speakers excellently they have deliberated this everything all these three topics. Just one or two important because my juniors students are PGTs are there. That is there. This is very important. Regarding one point regarding CMB, there is a no specific. Sometimes it is very difficult to take the decision in those some situation. Asymptomatic, very high urinary DNA copies, then what to do? Should we start treatment or not treatment? Because we know that there's a ganciclovir has a lot of side effect. So those things, those decision was sometimes difficult. Regarding Dr. Pahari has mentioned in detail about the infection in nephrotic syndrome. Nephrotic syndrome is actually in the patient is highly susceptible to infection, not due to the disease itself, the loss of opsonin, chance of phagocytic action is poor and high in chance of capsular bacteria, but all capsulated bacteria, but also there is a suppression of immunity by steroid. So you have to take both things together, and high index of suspicion is important. What I mentioned in my PGTs in the everyday round, I ask them for all nephrotic patient, please go to the side of the patient and examine the abdomen for any tenderness, because many of the time serious infection is so asymptomatic. You have to do the high index of suspicion to rule out infection, especially spontaneous bacterial peritonitis. And one infection is devastating in nephrotic syndrome, especially the nephro ward. That is chickenpox, varicella. So if you get any varicella infection, you have to separate all patients from that area and start acyclovir immediately, because I have seen devastation within and encephalopathy within 48 hours, varicella in a nephrotic syndrome patient. So that is a very dangerous infection in nephrotic syndrome. We should always think and exclude this thing. And another very important, varicella, sometime there is no typical manifestation of varicella rash in nephrotic syndrome because of steroid. So it is sometimes asymptomatic and sometimes very atypical presentation of varicella in nephrotic syndrome. Regarding the last presentation by my brother, Dr. Shuman Poddar, yes, fever is beneficial. Fever is beneficial because it's a condition he told also to inactivate virus. Many viruses are inactivated by virus. That is the reason is a body response. Fever is there. So no, don't go for aggressive way of fever reduction by applying everything. And most important is the sponging, warm tepid water sponging, not warm tepid water sponging, not cold. Cold water is not indicated because already mentioned. He has mentioned that there is a vasoconstriction and temperature is never lost in that situation. But another thing is also not important. That is, in Bengali film from Uttam Kumar with Suchitra, we have seen the jol potti. Jol potti actually never works because you have to put this weight compression in those areas where there's a big blood vessels are there, like groin, hand and foot, arm and leg, and axillary area and neck. That is the area we should go for sponging rather than keeping only the jol potti over the forehead. So that is important. And only one fever. Can any PGT say the only one fever you have to go for ice cold sponging? Normally it is not required. Can anyone from back PGTs? Very common. One-time hemorrhage is not that much common. It is the rarest of rare things. So, yes, it is the heat hyperpyrexia or heat stroke where only the indication fever reduction by applying cold water, not the normal which is due for the other fever. This is very important. And one thing, last I have mentioning about that. Now this typical pattern, Dr. Shuman Poddar has mentioned, the typical pattern of fever, step level, these things have changed, like our previous clinical book like MacLeod or Hutchison. মানে আমি এখন মনে করি বেশিরভাগ পিজিটি তারা নামই শোনেনি Hutchison আর MacLeod এর কেউ পড়েও না, like that fever has already changed.
now the fever, this even typhoid fever, it is no step ladder pattern, continuous fever. We are seeing hundred of cases admitted, no typical temperature rise, normal temperature is continuing. Because reason may be many, because maybe change of the bacterial this thing response, and another thing is the use of multiple antibiotic outside may lead to this kind of problem. And also malaria also, there is a no typical fever with chill and rigor. We have diagnosed a few hundred of cases, the patient presented with normal, only fever, mild to moderate fever. There is a no chill and rigor. Even there is a no vomiting, which is a part of the characteristic part of malaria. So that is how it is changing. So we should aware of this thing, and definitely we should treat accordingly. Thank you very much. Thank you, the organizer. Thank you, Helion, for organizing this kind of short, informative academic program. Thank you very much, and thank you, Dr. Otonu Bhadro, for inviting me. Thank you. Senior citizen, we respect. It is free for them, but for the junior, please do come, because you will be benefited with this program. It is at on the 15th of May at the Chittoranjan Shishodhan. Is the first time we are doing with a national expert on different field, particular field, different tropical condition are coming, and they are delivering. Please do register. Registration is only 500. So with a five credit point for West Bengal University, West Bengal Medical Council. Thank you.
So I think thanks a lot, sir. Thank you, ma'am. Thank you all the faculty members and the speakers for joining in for the program. As from the Helion team, I think again congratulations, and I think thanks to Dr. Atanu sir for helping us organize this entire event. Also, we have the brands. I think well-known brands. Again, I'm just sharing the quality products from Helion, which is starting from Crocin drops. It is available in multiple formats with suspension, which is 120 to 40, as well as now we have the higher dose available. Excellent flavor, especially when it comes to kids, where we understand palatability or the flavor matters. So we have the entire portfolio where we have strawberry mixed fruit in the double suspension. So again, the kids are going to like it. And again, the quality has been maintained in all our products. So thanks again. I think now we can proceed for lunch, and thanks again to all the committee members for helping us organize this event. Thank you so much.
ল্যাপটপ খুলছি না